Hello, Psyche community, and welcome to today's webinar, Behavioral Health HEDIS Measures, an annual update from NCQA. Thank you for joining us today. I am Heathen Patadia, a managed market liaison for Otsuka Pharmaceutical Development and Commercialization, Inc. I'll be serving as the moderator for today's exciting discussion featuring Dr. Liu and Ms. Nguyen. As the measure lead of NCQA's behavioral health measures, Dr. Liu guides the reevaluation and updates of HEDIS behavioral health measures. Dr. Liu's research focuses on access to mental health services, evidence-based treatment for behavioral health problems, and child welfare services. Dr. Liu was previously a research assistant professor at the University of Maryland School of Social Work and conducted the evaluation of a federally funded research project on the implementation of evidence-based practices in child welfare systems in 6 states. She holds a PhD and a master's in social work from University of Albany. She received her undergraduate degree from China's Youth University for Political Sciences. Joining Dr. Liu is Ms. Nguyen. Ms. Nguyen currently serves as a senior healthcare analyst in the Performance Measurement Department at NCQA. She manages, leads, and coordinates activities related to the development of quality metrics for the U.S. healthcare system. Her area of focus includes mental health, substance abuse, and pain management. Ms. Nguyen holds a MS degree in physiology from Georgetown University and a BA in cognitive science from the University of Virginia. Today's presentation is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Lundbeck LLC, committed supporters of the mental health treatment community. Speakers are paid consultants to OPDC. The information provided during this program is for your educational benefit only. No CME or CEU credits are offered. It is not intended as, nor is it as a substitute for medical care or advice or professional diagnosis. Users seeking medical advice should consult it with their physician or other healthcare professional. While conducting this session, our speakers aim to provide you with information that is accurate, not misleading, scientifically rigorous, and which does not promote Otsuka products. You may notice that all attendees have been muted. We are recording today's event, and muting the phone lines assures the highest quality of sound. We will, however, hold a brief question and answer session at the end of the presentation. And to participate, we encourage you to submit questions via the question box on the GoToWebinar panel at any time during the presentation. Before we begin our formal presentation, I'd like to take a moment to review our objectives for today. We'll be providing an overview of quality measurements and review changes to the behavioral health measures. We'll also be learning about the collaboratives by NCQA. We'll discuss the NCQA behavioral health programs, and we'll also highlight HEDIS behavioral health measures in the Certified Community Behavioral Health Clinic program. And with that, Ms. Nguyen, would you take us away into the presentation?
So I'll kick off our discussion today with NCQA's measure development, reviewing what HEDIS is, our behavioral health measures, and then outline changes made to the measures over the last year. So HEDIS stands for Healthcare Effectiveness Data and Information Set. And it's a tool that is used by more than 90% of health plans across the US to measure performance on healthcare quality measures. The measure set includes over 95 measures across 6 domains of care, including behavioral health. And these measures are developed and maintained to align with clinical practice guidelines, evidence-based practices, and expert consensus. Now, the core question here may be, why is measuring quality important? And it's important for various reasons, but mainly it tells us how the health system is performing against recognized quality standards so that we can achieve improved care over time. Measurement helps foster accountability, incentivize improvement, and standardize assessments to allow for comparisons of care. Our HEDIS measures are widely used in national, state, and accountability programs, including CMS, Medicare star ratings, and Medicaid core sets, and clinician quality rating programs, reporting programs, such as quality payment program. So just to provide a little bit of background in case you're less familiar with quality measurement, this slide describes the core components of quality measures. Measures can assess a variety of different things, including processes, outcomes, and events. And all of this first begins by looking at the population for which you're assessing. So we start with the eligible population, the initial patient population, and it's the broadest group of individuals, even appropriate for assessment based on general criteria relevant for the measure. So for example, their age, ensuring they're enrolled in the health plan with appropriate benefits, etc. And then the denominator is the population that's actually evaluated by the measure. For some measures, it may be the same as the eligible population, and others, it may be a stricter subset of it. For example, a measure that's assessing treatment for opioid use disorder may first want a denominator that captures members who have a diagnosis of opioid use disorder. Some measures also have exclusions, which mean they exclude certain individuals or events that are not eligible for that specific type of measurement. And typically, we exclude individuals due to specific diagnosis or condition. So for example, majority of HEDIS measures exclude members receiving hospice services. And finally, the numerator is the criteria that identifies the target, process, outcome, or event. A process could be something like ensuring that a certain evidence-based practice is adhered to. So an example of the measure around treatment for opioid use disorder, the numerator might be ensuring that treatment was provided to the individuals with opioid use disorder. Other things may be like assessing for an outcome. So for example, the population that showed improvement in their health over time, or looking for something like an event. An example could be maybe capturing events that occur that could be indicative of high-risk populations. So through our work in this field of quality measure development, and especially for behavioral health, we've identified a number of challenges to improving behavioral health care. Some of the challenges are listed here on the slide. So one of them is disjointed accountability. For example, having things like carved out benefit structures and issues with behavioral health data flow across different providers within a patient's care team. Thin evidence and changing policy. So for some of the clinical conditions within this domain, evidence is still emerging and the policies are rapidly changing. So it's certainly a time where we're seeing a lot of movement in the landscape. Also, under documentation and stigmatization around some of these conditions is also a big challenge for us, especially due to some of the types of data sources that our measures rely on, which are primarily claims data. And also just currently where the field is today, which is there's a limited focus on outcomes and goal attainment in behavioral health treatment. So all of these issues together are struggles that we continue to work through, but we do see a brighter future as we improve awareness around these challenges, continue innovation in our data collection and assessments, and move toward more concerted efforts around data integration and quality improvement. So now let's transition to look specifically at our behavioral health measures in HEDIS. So that includes both mental health and substance use measures. Again, HEDIS is comprised of nearly 100 measures. Of those, we currently maintain about 22 measures for behavioral health. This slide includes mental health measures, and as you can see, there are quite a large number of measures, so I won't read through each one, but speaking at a more high level, you can see that the measures can be organized by the specific domain for which they are assessing, and also by the conditions for which they assess. Some of these measures are currently under evaluation for changes by NCQA, which I'll speak to in an upcoming slide. But by looking at our current portfolio, you can see that we address various aspects of care. So screening and follow-up, monitoring, medication management, and others. The majority of the measures focus on conditions such as depression and schizophrenia, but we do have a number of measures that include all mental health conditions as well. And it's not listed on the slide, but the data sources for these measures do vary slightly. The majority of them use administrative claims data, but some, specifically the depression screening and follow-up measures, use electronic clinical data systems, also known as ECDS. And this means that they can capture data beyond claims data. So that includes things like EHRs, registry, case management systems as well. And this is all a very innovative space. We're continuing to learn more as it develops, and Junqing will actually talk more about this in her section as well. So this slide outlines our substance use measures. It's organized very similarly to the previous slide. The portfolio addresses different domains of care, including screening, continuity, and access, and it captures population using different substances, so alcohol, opioids, and other drugs. On this slide, we also include the opioid overuse measures. These are our pain management measures related to substance use. I just wanted to display these here because they are closely tied to behavioral health. Again, these measures use administrative claims data with the exception of the alcohol screening and follow-up measure, which uses ECDS. And just like with the previous slide, there are a number of these measures that are currently being evaluated for changes, and I'll speak to them in an upcoming slide. On this slide, I just wanted to show you an example of how we think about measure development for some of these measures, their position along the care continuum, and how the different measures complement one another. So this slide provides an example of our logic using SUD measures. The care continuum for SUD treatment is in blue, and then the measures for SUD are in the gray boxes. The graphic is meant to show you that we think about our target population as a whole and consider how the course of care may look for these individuals. So for SUD, the treatment pathway could begin with individuals who maybe just had a drug misuse event without a formal diagnosis, and then it could progress to receiving a diagnosis and then being treated and monitored for a continued period of time. The measures are meant to show you that we attempt to capture populations across the continuum with a focus on the areas in the treatment pathway that may be most critical. So before I hand it over to Junqing, I wanted to spend a few minutes reviewing some of the updates made to the measures since last year, as well as some of the work that's currently taking place. So over the last year, no substantial changes, but we did make a few updates to some of our existing measures. So for the follow-up measure for mental illness, we revised the numerator criteria to allow additional behavioral health settings to be captured in the measure. For the depression screening and follow-up measures, we revised the screening thresholds to focus the measure in on the population that has at least a moderate level of depression symptoms. We also did some restructuring to simplify the measure stratifications and revised the time period for screening in the postpartum measure. For the unhealthy alcohol use screening and follow-up measure, we revised the timing of the alcohol use disorder exclusion to only exclude members who have alcohol use disorder the year prior to the measurement year. And for two of our opioid overuse measures, we added an exclusion for members receiving palliative care. And this is actually a cross-cutting exclusion that applied to a number of our HEDIS measures this year. And lastly, in response to the COVID-19 crisis, we expanded allowance for telehealth in a number of our measures. NCQA's approach for this expansion included reviewing all of the HEDIS measures individually and then considering whether or not expansion for telehealth was needed and or appropriate. About 8 of our behavioral health measures ended up being impacted. So just to speak to telehealth, this telehealth update a little bit further, I want to be clear that telehealth includes a variety of different modalities, including video conferencing, telephone, and asynchronous visits. So before the pandemic, a number of our measures already included telehealth, especially video conferencing. But in response to the current crisis, NCQA added telephone and asynchronous visits to measures that did not include them before, removed some of the restrictions limiting telemodalities, and also made sure to incorporate the new billing codes that were released related to telemedicine. So as far as where we stand now, we have some work on our measures currently underway, which I've divided up into 2 different batches. We have work being done on our first year measures, which include entirely new measures that were added to HEDIS last year. So that's the follow-up for high intensity care for SUD and pharmacotherapy for OUD. And a new product lines that were added to an existing measure, specifically that's the Medicare and commercial product lines to the measure adherence to antipsychotic medications for individuals with schizophrenia. For these 3 measures, we are performing first year analyses, which means we are reviewing performance data collected from their first year in HEDIS. We're reviewing these results and vetting them with our panels to ensure that the measures are feasible for reporting and demonstrate importance through display of a performance gap and opportunity for performance improvement. And then the second group of measures are our existing measures. So 3 of our measures are under reevaluation for updates and revisions. These include the SUD access to treatment measure, so the initiation and engagement measure, the SUD utilization measure, and the mental health utilization measure. The goals of these updates are to align the measures with the updated evidence and improve their validity and overall usability. We're also looking at making updates to other existing measures as well. So for a number of our behavioral health measures, we're looking into the addition of collaborative care codes. And for the follow-up after ED visit for SUD measure, we're considering inclusion of pharmacotherapy in the measure and potentially expanding the measure's denominator population to capture poisoning events. So most of the changes I just described for the existing measures are NCQA public comment period this upcoming February. So we look forward to receiving additional comments and external feedback during that time.